Okay, so today we're going to be talking about pilar and sebaceous neoplasms. So this corresponds to chapter 4 with the Elson textbook. So, first one. So we have kind of the rolls and scrolls kind of architecture. And then we have these basaloid cells, but then we also have these pink cells that don't have a true nucleus. So those are ghost cells. So this is a pilomatricoma. So you have basophilic cells that look like hair matrix that keratinize to form shadow or ghost cells. A lot of times there's calcification, and you may even see bone formation. So they are associated with the CTNNB1 gene, which is related to the WNT pathway, and it encodes beta-catenin. And multiple pilomatricomas can be associated with some different syndromes, including myotonic dystrophy, Gardner syndrome, and Rubinstein-Tavy syndrome. Okay, next one. And this one can be a little tricky. So I think if you were looking at it at first glance, you might think like, oh, this looks like a basal cell carcinoma because you do have these islands of basaloid cells. But there's not any retraction artifact, and there's not really like that fibro myxoid stroma. It's more like hair follicle kind of just stroma. So this is trichoblastoma. Um, but it does look like basal cell. And then you can see some concentric collagen and a lot of fibroblasts in the stroma as well. And you don't have mucin in the stroma, but you can have it in the tumor islets. Next one. So you have these little structures that look like immature hair follicles or not fully developed hair follicles, and you have some calcification here. So this is your Paisley tie differential or your tadpole differential, whatever you want to call it. So this one is trichoepithelioma. So it's actually considered a type of trichoblastoma. And you get these basaloid cells that are kind of like forming a hair follicle, and then you may see papillary mesenchymal bodies, which are just like little cells around the area. So like it's hard to tell at lower power, but like this might be like a little papillary mesenchymal body, like just cells like by the little immature hair follicles. And then you may have mucin in the islands, but not in the stroma, and there's no retraction artifact, and it's not connected to the epidermis. So if you have multiple of these, it can be related to either Brooks-Spiegler syndrome or Rombo syndrome. Um, and then these are also CK20 positive and Philadelphia 1 positive, which is good to know. Okay, next one. So the big thing you notice is you have this big, what they call fibrous orb with some basaloid strands within it. So this one is Fibrofolliculoma. So you have a fibrous pink orb with epithelial strands. This is associated with Birt-Hogg-Dubé as well. And then the way you differentiate it from a trichofolliculoma is that this has fully formed vellus hairs within the hair shafts. Um, and they're usually just little skin-colored papules on the head and neck. Okay. So this one, this is the mama and babies. So you have one big hair in the middle, and then you have like a bunch of little baby hairs kind of coming off of it. Um, so this is Trichofolliculoma. So you have many small hair follicles emptying into one follicle. And then clinically, it's like a bunch of hairs coming out of one central pore. So if you see that on a Kodachrome, it's Trichofolliculoma. Okay, next one. So these are like they call them like donuts or Cheerios or different things. It's just like very what I like to think of as like dilated primitive hair follicles. Um, well, maybe not so primitive, but follicles. And so this is trichoadenoma, or some people also say it looks like eyeglasses. So you have small keratin-filled microcysts with minimal to no basaloid follicular epithelial structures, and then you have sclerotic stroma as well. So like you can see like here it's like pretty sclerotic compared to the surrounding dermis. Awesome. Okay, next one. So this one, you have like a central invagination with some loose keratin, and then you have some budding coming off of the epidermis surrounding it. So this one is just your classic dilated pore liner. It just looks like a dilated hair follicle, basically. And then you have these small little finger-like epithelial projections versus this one. And sorry that this picture is a little bit blurry, but this one looks very similar, except for the fingers coming off are just a lot fatter. So that is a pilar sheath acanthoma. So just when the fingers are thicker, that's pilar sheath acanthoma. Okay, so this one has more like clear cells. They're just filled with glycogen. And I know you can't see the bottom here, but usually it has like a more round bottom. And is it invading deeper into the dermis? So this is Trichilemmoma. So a lot of times it's kind of warty too, which like you can see, maybe you can see it a little bit here. It's kind of papillomatous. So that's common in this. And then you have a lot of clear glycogenated cells coming off of the epidermis. And this is associated with Cowden syndrome. So if you have multiple, it's diagnostic for Cowden syndrome. And then in terms of immunostains, they're pan-keratin positive and CD34 positive, which marks outer root sheath differentiation. And the difference from clear cell acanthoma is that it's not endophytic. Okay, next one. So you have like a pretty normal epidermis up here, and then you have these what they call garland-like strands coming off of the epidermis, kind of connecting underneath, and it's like a little pink, I would say. So this is tumor of the follicular infundibulum. It looks like follicular infundibulum, and it's kind of plate-like. Um, and then it may be adjacent to a basal cell carcinoma sometimes. Okay, next one. So the main thing here to note is that there are not really any true hair follicles, and you have sebaceous, like a lot of sebaceous glands just kind of going straight into the epidermis, which normally they're like going into the hair follicle, which then connects to the epidermis. So this is Nevus sebaceous. So it kind of changes pre and post puberty. So after puberty, it kind of gets more bumpy and more raised, but before it's just like a smooth plaque. And then they are actually hamartomas of follicular, apocrine, and sebaceous glands. So like I said, no fully formed hair follicles. The sebaceous glands go directly onto the skin surface, and it can be associated with Schimmelpenning syndrome. The most common neoplasm to arise within a nevus sebaceous is trichoblastoma, followed by syringocystadenoma papilliferum, and then tricholemmomas, peromas, basal cell carcinomas, and tubular apocrine adenomas. So that is something that they like to ask too on practice questions. Okay, next one. So this one you just have like a ton of normal looking sebaceous glands, like more than you would normally have, but they look normal. So this is just sebaceous hyperplasia. So these present as yellow papules with a central dell. And that central dell kind of like corresponds to like here, how they're like all emptying into the one hair follicle, basically. Perfect. Okay, next one. So this you can tell is kind of sebaceous. Like you see some sepocytes here, but you also see more like basaloid cells in there too. It's not just all sepocytes. So this is Sebaceoma. So you have basaloid and mature sepocytes in varying proportions. So some people say sebaceous adenomas are when it's less than 50% basaloid cells, and sebaceous Epithelioma or sebaceoma is when it's greater than 50% basaloid cells, but some people have also disputed that. And this can be associated with Muir-Torre syndrome, which you get multiple sebaceous neoplasms, KAs, and then you're at increased risk for other cancers like colon cancer and GU cancers. Okay, next one. So again, you can tell that it's sebaceous because you see some more like sebaceous type cells. But then you also have these basaloid cells that look abnormal, like their nuclei are pretty big. I'm seeing if I can find any mitotic figures, but you might see those in there. But basically, it just looks more malignant. So this is a sebaceous carcinoma. So you see foamy cells with scalloped nuclei, and you see atypical cells extending into the epidermis or the conjunctiva in kind of a nested or buckshot pattern. And then the infiltrative border may be apparent as well. And that is it. So we will be back with another one soon.